Okay, hello everybody. Thank you for logging in with us. Due to some technical difficulties, we are starting a few minutes late. I apologize for that. This is Dr. Lukena Karkhanis, and given how many questions are popping up for everybody regarding reactions to the brand new COVID-19 vaccines that we have, I thought it would be very helpful for all of us to talk a little bit about these vaccine reactions, what to do with them, who can get the second dose, who should not get the second dose, and things like that, okay? So just a little bit of background, COVID-19. So the COVID-19 pandemic, also known as the coronavirus pandemic, is an ongoing pandemic of coronavirus disease 19, which is what COVID-19 stands for, and it's caused by severe acute respiratory syndrome coronavirus 2, SARS-CoV-2 virus. This pandemic has caused global social and economic disruption, including the largest global recession since the Great Depression, so the biggest recession of our lives. And we have over 100 million cases and over 2 million deaths worldwide already due to COVID-19. Now, the good news is that recently several vaccines have been approved for use. So in the United States, we have 2 COVID-19 mRNA vaccines approved for emergency use, the Pfizer-BioNTech and the Moderna vaccines. But worldwide, we have several other vaccines. We have the adenovirus vector vaccine, so the AstraZeneca, Johnson & Johnson, and Sputnik vaccine from Russia. And then there are some inactivated virus vaccines, the Bharat Biotech vaccine from India and the Sinopharm vaccine from China. And overall, to date, about 110 million COVID-19 vaccine doses have been administered worldwide, of which about 34 million doses have been administered in the US. So it's encouraging. We have more doses administered than cases today, and I think we're going in the right direction. So let's talk about vaccine reactions in general. There are several different ways in which we can classify vaccine reactions. We can talk about their immunological classification, and they get classified as type 1 or 2 or 3 or 4, depending on what immune mechanism is involved in that particular reaction. You can classify them based on their severity, either minor or severe, based on their timing, immediate or delayed, based on their extent, are they local, do they spread systemically to other parts of the body, and then based on their mechanism, are they allergic reactions, are they non-allergic reactions. So instead of trying to classify them all of these different ways, I thought we are going to discuss them just clinically. When you see a reaction, is it minor immediate, is it minor local, is it severe immediate, and things like that, okay? So let's talk about the minor non-allergic, usually immediate minor non-allergic COVID-19 vaccine reactions. So these usually occur within a few hours of injection. So these are pretty immediate, and they resolve after a short period of time, maybe 24 to 48 hours. They pose very little danger to the vaccine recipient. They can be local, so a lot of people will report pain, swelling, and redness at the site of injection. Or they can be systemic, fever, chills, malaise, headache, or muscle pain. These are the commonest reactions really seen after any vaccine. So there's nothing new about the COVID-19 vaccine causing these reactions. We see these after the flu vaccine and the tetanus vaccine and really any vaccines. And we all kind of know how to treat these. You just do supportive treatment with rest and fluids, and you take Tylenol or Advil or other non-steroidal anti-inflammatories as needed. These really are kind of expected and don't really have to be bothered with much. What are some other minor non-allergic COVID-19 vaccine reactions? So a lot of people report this reaction that involves tachycardia, so a very fast heart rate or palpitations, elevated blood pressure, and a feeling of throat closure, what's called a globus sensation, something stuck in the throat or throat closing, sometimes within minutes of receiving this injection. These can be confused with anaphylaxis. They can be hard to differentiate from anaphylaxis, but a lot of these are not true allergic reactions. They often resolve just with rest. Sometimes the patient may end up getting some supportive care like antihistamines or fluids or other medications. It can be very hard to differentiate these from anxiety attacks. It's not unusual to be very anxious, and symptoms of anxiety attacks can mimic allergic reaction symptoms very closely and can be very hard for even healthcare providers to differentiate. There is some thought that some of these, especially the tachycardia, the palpitations, may be due to direct effects of the vaccine on our innate immune receptors like our toll-like receptors. So providers who are at vaccination sites, if you see a reaction like this, if you are able to, then please draw a tryptase level. A tryptase level is a blood test that you can draw and send to the lab. And if this is done within 2 hours of the reaction, it can help us differentiate an anxiety reaction or a non-allergic reaction from a true anaphylaxis or a true allergic reaction. And it's important to differentiate this because everything other than true anaphylaxis, really we should be getting the second dose of the vaccine to give that individual the maximum chance of fighting COVID successfully. So drawing that blood test for a tryptase level, if possible, will help a lot later on to differentiate whether it was a true allergic reaction. Another very common non-allergic reaction seen after many vaccinations is what's called a vasovagal reaction. So people get lightheaded, they get palpitations, their heart rate goes up, their blood pressure can actually drop, they may pass out if they're not sitting down, and they can have jerks of their arms and legs, their extremities that look like myoclonic jerks. These usually resolve with rest, putting the person in a head-low position, sometimes with fluids. These are seen with many injections and blood draw procedures. Sometimes these vasovagal reactions can happen a few hours later if the person wakes up and happens to be dehydrated or is having other side effects like chills or weakness. These reactions typically are worse with even borderline dehydration. So everybody should kind of keep an eye on their hydration status. When you're going to get a vaccine, any vaccine, you are going to put a little bit of stress on your body due to your immune system being activated. So be sure to not be dehydrated, carry fluids with you, make sure that you have eaten and you're not going on an empty stomach. Because of the presentation, sometimes vasovagal reactions can be confused with anaphylaxis because the patient passes out, their blood pressure is low. They can be confused with seizures because oftentimes jerks of the arms and legs are seen. And again, drawing that blood test to check for a tryptase level within about 2 hours of the reaction can help differentiate them from true anaphylaxis. And vasovagal reactions are not a contraindication to getting a second dose. So it's important to kind of tease out exactly what happened and what kind of reaction it was. We just again recommend that you hydrate very well and you rest for about 50 to 30 minutes, possibly with your head low. So lying down if possible after the injection to avoid another vasovagal reaction. What are some minor allergic COVID-19 vaccine reactions? So some people report hives or swelling, maybe in the face or the arms or legs, or a sensation of wheezing or noisy breathing within minutes of receiving the COVID-19 vaccine. Some of these may resolve with oral antihistamines or similar medications. Now, hives or swelling or wheezing that happens within minutes of receiving an injection is indicative of a true allergic reaction, though it's minor, not life-threatening, but it's what we call a type 1 hypersensitivity reaction or a IgE-mediated reaction. Now, patients who report these, send them to your friendly neighborhood allergist. They should see an allergist to decide whether they should receive the second dose. It's important to do this because some of these patients, their hives are not from the injection. Some of these patients have had hives in the past. They break out into hives with viral infections or with any kind of stress. And these hives are actually due to immune activation, not the vaccine itself. Some of these patients have chronic swelling or angioedema syndromes. Some of these patients are asthmatic, and what they're seeing is an asthma flare-up and not really a vaccine reaction. So they do need some special consideration from an allergy specialist to decide whether they should receive the second dose. And they may benefit from testing to the vaccine itself or to vaccine ingredients if the allergy specialist thinks that this is indicated. So somebody that reports hives or swelling or wheezing within minutes of receiving the COVID-19 vaccine ideally should see an allergy specialist to see what's going on. What are some minor delayed COVID-19 vaccine reactions? So this is a picture of what's being termed the COVID-19 arm or the Moderna arm or the Pfizer arm, right? So basically the site where you got your shot 7 to 10 days later becomes red and itchy and swollen. So this is a delayed large local reaction to the vaccination. And it happens several days after the vaccination. And it is due to activation of a very specific immune cell called the T cell. So this is almost like the reaction you get to a PPD test or a TB test. This is not an allergic reaction to the vaccine itself. It's a delayed kind of large local reaction. People with sensitive skin will often see this kind of reaction even to other trauma like insect bites. Treatment is supportive. You can take oral antihistamines like Benadryl or Zyrtec. You can take some Tylenol or ibuprofen as needed if it's very painful or uncomfortable. You can put some topical steroids like hydrocortisone ointments. And again, this is not a contraindication to the second dose. That T cell activation reaction actually is a good sign that your immune system is getting activated by the vaccine. Now, though it's not a contraindication to the second dose, this may happen again with the second dose. It may recur. So you have to be ready to treat it again with supportive care. And we can't be afraid of these minor delayed reactions because we weigh the pros and cons. We would rather have a red itchy arm for about a week or so than end up with coronavirus infection in the ICU. So clearly the risk-benefit ratio lies in benefit of getting the second dose. You just got to be ready to treat it. But keep in mind, this delayed COVID arm reaction is not an allergic reaction. So if somebody reports this to you, please tell them that they are okay to get the second dose and they should be ready to treat it if it recurs. What are some other minor delayed vaccine reactions? So people are concerned about Bell's palsy. So there were some cases of Bell's palsy seen in the Pfizer and Moderna trials, 4 cases in the Pfizer trial, 3 in the Moderna trial. They were all in the vaccine arms. They were not in the placebo arms. But per the FDA, this is not more than what is expected for the population incidence of Bell's palsy just in the normal population. So as of now, we do not think that the vaccines caused Bell's palsy. And that is why past history of Bell's palsy is not a contraindication to the COVID-19 vaccine. Now keep in mind, any viral infection, including COVID-19 infection, carries a risk of Bell's palsy because the main trigger for autoimmune conditions like Bell's palsy really is infection, not so much vaccine. Now people that do develop Bell's palsy, the care is supportive. Supportive care, steroids like you would normally treat a Bell's palsy case. Some people are concerned about swelling at the site of dermal fillers as seen in the Moderna trial. 3 cases were reported there. And after vaccination has started, some other cases have been reported. Dermatologists report that they have always seen similar swelling with viral infections, not so much with other vaccines, but infections like influenza will often cause swelling in their dermal filler patients. And they think it's due to some kind of inflammation at the filler interface. And that's why fillers are not a contraindication to the COVID-19 vaccine. This swelling is temporary, it resolves, we just treat it with antihistamines, Tylenol, ibuprofen as needed. But if it does happen, just know that this is not an allergic reaction, it's due to inflammation at the filler and your skin interface. Lymphadenopathy. So lymphadenopathy is lymph node swelling, and cases have been reported in all the vaccine trials as well as after vaccination has started. People have reported cases too in the general population. Now, this lymphadenopathy is usually temporary. It's mild. It's usually axillary, meaning in the underarms, or supraclavicular, above the clavicle, and it's almost always on the same side as the vaccine administration. So the arm that you got your shot in, that's where you will develop swollen lymph nodes, in that underarm area, in that clavicle area. This again is not an allergic reaction to the vaccine. This is due to activation of your adaptive immune system in your local lymph nodes. So this is actually something we want. We want the vaccine to activate our immune system, and the way it does it is by these little local centers that filter everything, called lymph nodes. And so obviously when they get activated, they become big, they start cell proliferation, and that's why they get swollen. Lymphadenopathy is not a contraindication to the second dose, but it may happen again. So if people are telling you they're having swollen lymph nodes, it's very much due to the vaccine, but it is not a contraindication to the second dose. It may happen again, but it's temporary, it's mild, it resolves just with supportive treatment. Most people really don't need any treatment at all. If it's very uncomfortable, you can take some Tylenol as usual. The only thing to keep in mind for women is that if you have a mammogram scheduled during the time that you're getting your COVID vaccines, the American College of Radiology actually recommends delaying the mammogram for about 6 weeks after the second dose. Because when you get a mammogram, they look for swollen lymph nodes in the axilla area. And if those lymph nodes are swollen because of your COVID vaccine, you're going to have to repeat the lymph node imaging. So if you have a mammogram scheduled, push it out to 6 weeks after the second dose so as not to confuse COVID vaccine lymph node swelling with any other kind of lymph node swelling. But again, this is not an allergic reaction. This actually is a sign that the vaccine is doing what it's supposed to do. It is temporary and mild, and you can get the second dose. Now, what is a severe COVID-19 vaccine reaction? So the one that we worry about, the one where we say you should not get a second dose, that's anaphylaxis. So anaphylaxis is a severe reaction. It's very rare. It has to have 2 or more organ systems involved. So on the skin, you might see hives, flushing, swelling, or throat closure. In the respiratory system, you might see wheezing or difficulty breathing, shortness of breath. In the cardiac system, low blood pressure, increased heart rate, so tachycardia, symptoms of shock. In the GI system, abdominal cramps, nausea, vomiting, or diarrhea. And you need at least 2 of these organ systems involved. The treatment is epinephrine, and that is why the recommendation is that all COVID-19 vaccination sites be equipped with epinephrine and staff that are comfortable diagnosing and treating these rare anaphylaxis reactions. Again, when you're suspecting anaphylaxis, because like we discussed before, sometimes anxiety attacks or vasovagal reactions can have 1 or 2 of these symptoms as well, draw a tryptase blood test level within 2 hours of the reaction. And in true anaphylaxis, the tryptase level will usually be elevated. If it comes back as normal, then we have to go back and think as to whether this was true anaphylaxis. Patients that have proven anaphylaxis to the COVID-19 vaccine should not get the second dose. So these people are going to have to figure out a different vaccine or a different way to protect themselves from COVID. And after about 2 million doses of the Pfizer vaccine in the first 2 weeks after its emergency use authorization, there were 21 reported cases of anaphylaxis in the VAERS system. The VAERS is the system that the US maintains for vaccine adverse event reporting. And after about 4 million doses of the Moderna vaccine, there were 10 reported cases in VAERS. Now, please keep in mind there were no deaths. So there have been no deaths from Pfizer or Moderna vaccine, not in the trial and not after emergency use authorization. And there have been no deaths from the vaccine in any of the vaccine trials worldwide. The problem with COVID-19 vaccine reactions, especially the severe anaphylaxis reactions, is that we haven't had enough time yet to figure out the specific mechanisms and the inciting antigen. We haven't yet definitively identified what part of the vaccine is triggering this. So definitely anybody that you suspect has this should see their friendly neighborhood allergist, because they should probably get tested to the vaccine itself and get their opinion as to what to do regarding the second dose. Why do we keep harping about second dose? Why are we so insistent that everybody get their 2 doses? It's because we want to maximize everybody's chances of fighting COVID-19 successfully. So these vaccines, they prevent severe COVID-19 infection very, very well. There were 0 reported cases of severe COVID infection in the Moderna trial, 1 case in the Pfizer trial in the vaccine arm, versus several cases in the placebo arm. So we know that they prevent severe COVID-19 very well, and they overall prevent all symptomatic COVID-19 infections, even mild infections, with about a 94 to 95% efficacy. So these are really good vaccines, and this is the way we are going to get ahead of this pandemic. And that is why we are always trying to make sure that everybody that can possibly get that great protection gets that great protection. It would be a shame to deny somebody a second dose of the vaccine and then have them develop severe COVID and develop some long-term sequelae from it. Studies are now showing almost 35% of people recovered from COVID go on to have long-term sequelae, and that is a lot. That is more than a third of the people that have long-term sequelae from a simple viral infection. So COVID is an odd disease, and that's why it's very, very important to maximize our chances of protecting ourselves. And that's why all of these testing and recommendations are geared towards giving every person their maximal chance of protecting themselves. So when is the COVID-19 vaccine contraindicated? So as doctors, we get questions all the time. Can I get the vaccine? Can so-and-so get the vaccine? So I put down most of the common questions that I have come across. So what if I have a previous history of food allergy? Previous history of food allergy is not a contraindication to the COVID-19 vaccine. The vaccines have no food proteins in them. There is no dairy protein, no soy protein, no gelatin, nothing in these vaccines. As usual, if you have a history of food allergy, you probably have an epinephrine auto-injector. So you just keep it on hand and you stay for observation for 30 minutes at the vaccination site. What about people that have environmental allergies, pollen allergies, mold allergies, dust allergies, pet allergies? No contraindication to the vaccine. There are no antigens like that in the vaccine, and the vaccine is not going to cross-react with any of your environmental allergens. Again, stay for observation for 30 minutes because you do have a tendency to have allergies, but really most of our patients with food allergies and environmental allergies are doing fine with the vaccine. What about a previous history of latex allergy? There is no latex in the vaccine. There is no contraindication for people with latex allergy, and you stay for observation for 30 minutes. Almost all places in the United States especially no longer use latex gloves. There is no latex in the vial stoppers. So really there is no contraindication for latex allergy. If it's your turn to take the vaccine, you should go ahead and take it. Previous history of insect venom allergy, bee sting allergy, fire ant allergy, wasp allergy. Again, no venom ingredients are in the vaccine. There is no contraindication. Keep your epinephrine auto-injector on hand, stay for observation for 30 minutes, and almost everybody is doing fine with the vaccine. There is never going to be a vaccine with zero side effects, right? Everything has a side effect, even oxygen and water. So we just have to monitor, and the majority of the population is going to do fine with the vaccine. What about a family history of severe allergies? There is definitely no contraindication to getting the COVID-19 vaccine if somebody in your family has a history of severe allergies. Just go ahead and take the vaccine, give yourself the best chance of fighting COVID-19 infection. Previous history of oral drug allergy, and this is your sulfa allergy, penicillin allergy, cephalosporin allergy, allergy to morphine and codeine. There is no contraindication to receiving the COVID-19 vaccine. There are some centers where this is often used as a screening test, and a lot of patients are then denied the vaccine, and that is really not correct. Previous history of oral drug allergy per the CDC is not a contraindication to the COVID-19 vaccine. The vaccines do not have any antibiotics in them. They do not have any preservatives in them. There is no mercury, no thimerosal, no gelatin. These are very, very clean, preservative-free vaccines. So previous history of any oral drug allergy, you are probably okay to get the COVID-19 vaccine. You can stay for observation for 30 minutes. What about a previous history of radio contrast dye allergy? So radio contrast dye allergy is usually due to the iodinated part of the radio contrast dye, and there is no iodine in the COVID-19 vaccine. So this should not be considered a contraindication for the COVID-19 vaccine. As always, for people that have a history of allergies, just stay there for 30 minutes so somebody can watch you and make sure you did okay. What about a previous history of contact dermatitis to something like neosporin or adhesives or any other kind of metals or rubber products? None of those products are in the COVID-19 vaccine. So there is no contraindication for patients with a history of contact dermatitis. What about people who have a previous history of an allergic reaction to another vaccine? So these people really should talk to their allergist. We do a deep dive and we can figure out what exact vaccine you reacted to, how severe was your reaction, was it an allergic reaction or was it a non-allergic side effect, was it life-threatening or not. Majority of patients with a different vaccine allergy can still get the COVID-19 vaccine. And we want to maximize our protection to the coronavirus disease, and that's why we are going to try and maximize the number of people who can get the COVID-19 vaccine. What about somebody that has a previous history of an autoimmune disease like Guillain-Barré syndrome? Guillain-Barré syndrome is a rare autoimmune condition involving the nerves, and in its most severe form, it can cause paralysis. It can sometimes even paralyze the respiratory muscles. Common triggers really for Guillain-Barré syndrome are viral infections, not so much vaccines. Most of the Guillain-Barré cases that we see are from viral infections like influenza, bacterial infections, and even COVID-19 infections. But there have been no reported cases of Guillain-Barré syndrome after a COVID-19 vaccine to date. And hence we right now say there is no contraindication. So even if you had Guillain-Barré syndrome from a previous different virus, you can go ahead and take the COVID-19 vaccine, and you probably should more than anyone else, because if you develop COVID-19 infection, it may reactivate your Guillain-Barré syndrome. So the infection carries a higher risk than the vaccine. We weigh our pros and cons and we go with the less risky option. What about a previous history of immune thrombocytopenic purpura? This is a condition where platelets drop down. So again, there have been no cases that have been definitively attributed to COVID-19 vaccine, and hence as of now, there is no contraindication to getting the COVID-19 vaccine if you have a history of ITP. As always, if you have a history of ITP, be on the lookout and monitor your condition. But as of now, there is no contraindication. What about a previous history of immune deficiency? So in fact, patients that have immune deficiency are high risk for serious COVID-19 infection. And not only is there no contraindication to the COVID-19 vaccine, these people should actually be prioritized to get the COVID-19 vaccine in the upper tiers, because they will do very poorly with infection. The COVID-19 vaccines worldwide, all the approved ones, emergency use authorization ones, none of them have any live virus in them. They are all live virus free vaccines, and hence there is no contraindication for any immunodeficiency patient to get the COVID-19 vaccine. What about people with a previous history of being on immune suppressant medication? Again, there is no contraindication, and just like immune deficiency patients, these patients are high risk for serious complications with COVID-19 infection. So we need to prioritize them and give them the vaccine in the earlier tiers. What about a previous history of cancer? There is no indication that the COVID-19 vaccine is going to reactivate your cancer, and hence there is no contraindication to getting the COVID-19 vaccine. What about elderly frail patients? So this question came out after there was a news article out of Norway that reported about 30 deaths in nursing home patients after receiving the Pfizer vaccine after Norway started vaccinating all their nursing home recipients. And they are looking into these deaths, but they have reported that on a daily basis, about 45 people die in nursing homes in Norway. Because keep in mind, these are very elderly. Most of them have serious medical conditions that have landed them in nursing homes. So the death rate in this population in general is pretty high. And all the investigations so far have not established any link between the vaccine and these deaths. So they are not attributing any of these deaths to having received the vaccine that day. It looks like this was just the normal kind of incidence of death in that population. And so they continue to vaccinate their elderly, and we continue to vaccinate our elderly, and there is no contraindication to the COVID-19 vaccine in elderly frail patients. Now, we have to be vigilant because elderly frail patients, especially in nursing homes, may not be able to communicate their side effects or their discomfort very well after getting a vaccine. So just like we monitor children, the staff need to be vigilant about monitoring the hydration status and adequately treating even minor side effects from the vaccine in these patients. A lot of our elderly nursing home patients are ones that we don't realize they have a urinary infection till they start falling because they're dizzy, or we don't realize that they have a pressure ulcer till they have an altered mental status. So similarly, the vaccine is a little bit of stress on the body. It is going to activate your immune system. We just need to be vigilant that these patients are being fed well, they are adequately hydrated, and any minor side effects are treated very, very quickly because we are going to put them under a little bit of stress. Now, keeping that in mind, we do need to assess these patients' overall status and their life goals. If we are talking about somebody who is on end-of-life care or hospice, we are not going to be pushing the COVID-19 vaccine on them. But if we are talking about somebody who's elderly but is leading a relatively independent, productive lifestyle, then they definitely will benefit from getting COVID-19 protection, because if they catch the infection, they are not going to do well. So how would you, your patient, rather fight COVID-19 infection? That's the question to ask yourself. We are not choosing between vaccine and placebo. We are choosing between fighting the infection with vaccine protection or fighting the infection with no protection. And depending on your patient's overall status and life goals, that is the question we answer. And if it's somebody that will benefit from the vaccine, they should get the vaccine. Another misconception is patients on blood thinners. So this is often a screening question on questionnaires for the COVID-19 vaccine. And if patients answer yes, then vaccinators are saying it's a contraindication, you cannot get the COVID-19 vaccine. So keep in mind, this is not a contraindication for the COVID-19 vaccine. That question is on that form because the recommendation is that you apply pressure at the injection site for 1 to 2 minutes. Ideally, this is a common sense measure. If somebody is on a blood thinner and you're going to give them an injection, you have to apply pressure, otherwise they are going to develop a local hematoma. But it's not a contraindication to getting the vaccine. Please do not deny these patients the vaccine. A lot of doctors, you may see patients calling you for letters stating this. And if your patient calls you, please clear them to get the vaccine. Oftentimes, vaccinating staff are not doctors, and they are not your patient's primary doctor or specialist doctor, and on the spur of the moment, they may just follow the algorithm on paper. They may not have the time to kind of go through the pros and cons and decide who should or should not get the vaccine. So for cases like this, if our patients ask us for a letter clearing them, then we should be comfortable clearing them to get the COVID-19 vaccine with the usual precautions. Now, the most interesting part that has had a lot of discussion but is still very vague and in the gray zone, is this previous history of PEG or polysorbate allergy. So PEG, PEG stands for polyethylene glycol, and polysorbate AT is a closely related compound. Pfizer and Moderna vaccines contain PEG, and the AstraZeneca and Johnson & Johnson vaccines contain polysorbate AT. These chemicals are solvents, they're plasticizers, they act as surfactants, they can be used as a base, and they are lubricants. That's why they add these. And the lipid envelope of all these vaccines, Pfizer, Moderna, AstraZeneca, Johnson & Johnson, all of them have lipid envelopes. The lipid envelope is what necessitates this PEG or polysorbate molecule to stabilize it and act as a surfactant. These PEG and polysorbate molecules are actually widely present in a lot of medications. They are present in Miralax. They're present in Depomedrol, which is a very common steroid injection that a lot of doctors keep in their office. They are present in many over-the-counter eye drops like Systane and Blink and Refresh and Soothe. And then they're present in some IV medications like Peg-Intron, which is an alpha interferon, Neulasta, Peg-asparaginase, and Paclitaxel, which are some chemotherapy medications. These have been hypothesized to be the possible antigen for COVID-19 vaccine anaphylaxis, but this has not been proven yet. So this was just the first kind of idea that came up. Is this what is causing the anaphylaxis? We have not proven it yet. So if somebody reports that they have a previous history of a PEG or polysorbate allergy and they want to know if they can get the COVID-19 vaccine, definitely refer them to an allergist for consideration for testing. We do have protocols set up now to start testing to these ingredients, but you have to keep in mind that the decision regarding whether that patient will get the COVID-19 vaccine or not will involve some shared decision making with that patient as to what their lifestyle is, what their other comorbidities are, what their risk for COVID and severe COVID is, because we don't even know for sure if PEG and polysorbate allergy are what are causing the anaphylaxis to COVID-19 vaccines. Right now, the vaccines are not widely available to allergists in their office, but there may be a time when they are easily available and we may actually have to test to the vaccine itself to know if a patient will do okay. You have to keep in mind that's going to take some time, because when you take out a dose to test, then that dose can't be given to anybody. So we don't really have spare doses yet to test to the vaccine. Let's talk a little bit about the timing of COVID-19 vaccine. So if you're on immunosuppressant medications, when can you take the COVID-19 vaccine? So talk to your doctor that prescribes your immunosuppressant medication. Most of the times, there is no dose adjustment indicated because we want to avoid a flare-up of your underlying autoimmune condition. We don't want your rheumatoid arthritis or your Crohn's to flare up just because we stopped your medication for the vaccine. Unless your immunosuppressant medication is a daily dose, try and separate the vaccine from your medication by about 2 days, at least 2 days. This is more to not confuse the side effects. So if you take the vaccine and you have a change in your health status, you will know it's from the vaccine and you won't be confused about side effects with immune suppressant medications. What about patients on allergy shots? There is no contraindication to the vaccine, and you again separate the vaccine from your allergy shot by at least 2 days to not confuse side effects. Efficacy will not change. So if you by mistake happen to get it on the same day and you don't have any side effects, well and good. It's going to be effective. Your allergy shot will be effective. Your COVID-19 vaccine will be effective. Your arm might be a little more sore than usual, but that's about it. So efficacy does not change. We just say separate so as to not confuse the side effects. What about people who are on immune globulin infusions like IV immunoglobulin or subcutaneous immunoglobulin infusions? There is no contraindication to the vaccine. Like I mentioned, the vaccine has no live virus in it. It cannot give you COVID-19 infection. It cannot make your COVID-19 test falsely positive. and separate the vaccine by at least 2 days from your infusions so as to not confuse the side effects. Efficacy will not change. Your underlying immune deficiency might make it a little less efficacious in you than in a healthy person, but it will still not bring the efficacy down to zero, and the immunoglobulin infusion will not affect the efficacy. And the current immunoglobulin products in the market contain no COVID-19 antibodies. So they are not going to neutralize your vaccine or anything like that. It's going to be at least a year, if not more, before COVID-19 antibodies show up in blood products, because right now all blood donations are checked, and the ones that are positive for COVID-19 antibodies are pulled out of the main pool and are not put in these main pool for blood products. What about patients that are on biologic medications? These are injections for asthma, eczema, nasal polyps like Xolair, Nucala, Fasenra, Sinclair, Dupixent. These are not immunosuppressant medications. They are what we call immunomodulatory medications, and there is no contraindication to the vaccine, and these medications will not decrease the efficacy of your vaccine. Again, separate it out from your vaccine by at least 2 days so that we don't confuse the side effects. But again, efficacy will not change. What about people that need another vaccine? So what about adults that need a tetanus, diphtheria, pertussis vaccine, or a shingles vaccine, or a pneumonia vaccine, right? So there is no contraindication to getting the COVID-19 vaccine. But since it's a new vaccine, we recommend that you separate the COVID-19 vaccine from any other vaccine by at least 2 weeks to not confuse side effects. These vaccines will not affect each other's efficacy, and if in 2 weeks you don't have any major side effects, we know you did fine. So hold on to your other vaccinations and separate them from your COVID-19 vaccine by at least 2 weeks. What about people that have recovered from COVID-19 infection? When can they get the vaccine? So if that person was not treated with a monoclonal antibody or convalescent plasma, they may get the COVID-19 vaccine as soon as they're out of quarantine. Now, if they don't want to get it right away, or if a vaccine is not available to them right away, they may do okay for about 90 days. So they could defer, or they could wait for a dose for about 90 days, but not more than that. And we have been dealing with COVID-19 for almost a year now. So there are many patients that are 6 months, 9 months from their COVID-19 infection. We really cannot reliably say that they will be protected from their infection. So these patients should not defer the vaccine. Now, anecdotally, people report more side effects with vaccine after a recent COVID-19 infection, but the Pfizer and Moderna trials saw no difference in safety or efficacy profile amongst those with pre-existing antibodies and naive people. So anecdotally, people say that if you recover from COVID-19 and you got the vaccine, you may have more side effects. But keep in mind, people that have side effects report them. People that don't have side effects don't really go around announcing that they did not have side effects. So there is some reporting bias in anecdotes, and that's why we like to depend more on trial data. And fear of side effects should not be the deciding factor. That's not what you should use to decide, should I get the vaccine or not, because side effects can be treated. COVID-19 infection cannot always be treated successfully. So side effects, we can treat you for them. Now, if you recently recovered from COVID-19 infection and you were treated with a monoclonal antibody or with convalescent plasma, then you should wait for 90 days to get the COVID-19 vaccine, because the monoclonal antibody or the convalescent plasma will have antibodies to that spike protein that these vaccines make in our body, and it may inactivate the spike protein that the vaccine makes before your own immune system has a chance to develop immunity to it. So wait for 90 days. However, if you got one shot, then you got COVID, and you got monoclonal antibody or convalescent plasma and had to wait 90 days for your second shot, you don't need to repeat the entire series. You just get your second shot and then you're supposed to be good. What if your second dose is delayed? So due to logistical reasons, a lot of people can't get their second dose at the exact 3 weeks for Pfizer or 4 weeks for Moderna. It's okay to get it 4 days early. It's okay to get it as much as 6 weeks after the first dose. Likely, it's okay to get it even later because we know from immunological data that typically a booster dose, which is what that second dose is okay to take a little later. It boosts your immune system just as well. And though we don't have data, it does not look like you will need to repeat the entire 2-dose series if your second dose is a little late. You can just take the second dose a little late and it should give you decent protection. And as we gather more data, we will know if what we think is going right. And that is kind of what we had. Now, these are my references and we have some questions come up. So, one question is, should we drive our loved ones to their vaccine appointment, or is it safe for them to drive? So it should be safe for most adults to drive to their own vaccine appointment. If it's somebody that's very elderly and frail, then go with them. But otherwise, the vaccine is just like any other injection that you get at your doctor's office. You're going to go there, you're going to get it, you're going to wait for some time, and you're going to be fine to drive back on your own. Another question is, I was told that this was not legally a vaccine. Is that true? So this is a little confusing. I'm not sure what this person is trying to ask. If you're saying, is this a FDA approved vaccine? It is not. FDA will not approve anything with 2 months of data. FDA has given this vaccine emergency use authorization because we are fighting this pandemic that's threatening to wipe out humanity. And as they gather more data, they will eventually approve it. But this is a legal vaccine. The studies have all been done. There has been extremely close scrutiny and all the due diligence was done. Everything was looked at in detail, and these vaccines were found to be very safe, highly effective, and that's why they have that emergency use authorization. That, by the way, is also very hard to get from the FDA. So this is totally a legitimate legal vaccine, and very soon we hope that we can call it an FDA approved vaccine too. It's just a matter of time. What does it mean if you have no reaction whatsoever to the COVID vaccine? So what it means is you got lucky. Okay, it doesn't mean that your immune system did not work or anything scary like that. You just got lucky. So the ability of a vaccine to trigger an immune response is called immunogenicity. And the tendency of a vaccine to trigger side effects is called reactogenicity. So scientists who develop vaccines want very good immunogenicity. They want the vaccine to make very good immune responses. They want minimal reactogenicity. They want the vaccine to cause very little side effects. So that is kind of what they are trying to do. They are trying to minimize side effects, maximize immune response. The side effects happen due to a different part of your immune system, the innate immune system as we call it. And the immune response actually happens due to a different part of your immune system, the adaptive immune system. So if you don't have side effects, that's fine. If your immune system is healthy overall, most people will still develop a pretty robust immune response. Most young people have very healthy innate and adaptive immune systems, so we see better vaccine responses and more side effects in young people. But there are plenty of young people that have minimal side effects and very good protection. There are older people that have a lot of side effects and very good protection. So if you have no side effects whatsoever, you just got lucky. That's great. What if you get COVID arm after your first dose? Should you get the second dose on the other arm? So this is completely personal preference, okay? It depends on what kind of work you do, whether your work involves any kind of procedures that involve using your arms, and how uncomfortable your arm was with the COVID arm. Most people I know are choosing to use the same arm, their non-dominant arm, especially doctors who do procedures like surgeons or anesthesiologists. They don't want their dominant arm, meaning if you're right-handed, your right arm, you're left-handed, your left arm, whatever arm you use to do surgeries, they don't want to be uncomfortable in that arm. So they choose to just get it on the same arm and just deal with it on that side, and that's done. But if you are in a job that doesn't really have any preference like that, it's up to you. There is not a medical reason to prefer getting it in the same or the other arm, because it's a temporary reaction and we hope that it will resolve on its own really, but otherwise with just over-the-counter medication. So it's very personal preference. What are your thoughts on getting the vaccine while on an antibiotic? Should we wait till the antibiotic regimen is completed? This depends on why you're on the antibiotic to begin with. If it's for something minor like a dental infection or a ear infection or a upper respiratory infection or a UTI, and you have stabilized, meaning you already started your antibiotic, you are already starting to feel better, you can go ahead and take the vaccine. If you are sick and you're not yet feeling well, you're on an antibiotic but you just started it and you're kind of feeling sick, you probably should wait till you feel good enough to get the vaccine, because the vaccine, like any other injection, is going to stress out your immune system a little bit, and you'll just trigger side effects that might feel more unpleasant because you're already having some symptoms from your underlying infection. The antibiotic per se doesn't have any effect on the vaccine. You're fine to get it. People who take antibiotics on a daily basis are getting this vaccine. So once you are stable and feeling well enough to get the vaccine, you can take it on an antibiotic. What about those currently pregnant or trying to become pregnant? So in the United States, the American College of Obstetrics and Gynecology and the high-risk OB group, or the maternal fetal medicine group, recommend that the COVID-19 vaccine should be given to all pregnant and breastfeeding women, all women desirous of conceiving, who want to take the vaccine. The reason for this is that the vaccine gives very good protection against coronavirus infection, and the infection can be catastrophic in pregnancy. We see a lot of ICU stays in pregnant women who catch coronavirus infection. We see a lot of preterm labor. We see a lot of babies born premature and then having long NICU stays. So the infection can be so very deadly, and the vaccine seems so very safe, that the current recommendation is that anybody desirous of getting the vaccine should be given the vaccine, even if they are currently pregnant or trying to become pregnant. The trials, the Pfizer and Moderna trials, did exclude pregnant women, but several women in both trials still ended up becoming pregnant after getting the trial vaccines. And the women who became pregnant in the vaccine arms of both these trials, they are doing fine. As of now, to date, there is no report of any adverse event in any of those pregnancies. They are progressing fine. There were some pregnancy losses in the placebo arms, but they were unrelated to the placebo shots. So really, it seems like this vaccine is going to be very safe for pregnant women. And the mechanism by which this vaccine works doesn't seem to have any scientific basis for being a concern in pregnancy. The mRNA that this vaccine contains is very temporary. It's very fragile. It's just going to stay locally, induce some spike protein production, and then it's going to be degraded within hours or days. It's not going to spread to the placenta. It's not going to go cross the placenta. It's not going to spread to the breast milk and be excreted in the breast milk. So really, there does not seem to be any mechanism by which it could harm a woman or a baby. In fact, like we give pregnant women flu shots and tetanus, diphtheria, pertussis shots, if they get this vaccine in their third trimester, if they happen to be in their third trimester, the antibodies that they develop, the immunoglobulin G antibodies, some of those good protective antibodies will cross the placenta and will provide the baby with some protection for a few months after they're born. So it may in fact help the baby a little bit if mom gets the vaccine when pregnant. I think that was about it in terms of live questions. Please feel free to reach out if you had a question and we were not able to answer it. And we will post this recording so people who were not able to watch it completely or who want to log on later and watch it again can go back and watch it as well. Thank you.